at 5 months on cetuximab, the patient starts experiencing symptoms that were concerning for progressive disease, fatigue, some nausea. CT scan performed did indeed confirm that the patient is progressing, and CA was 89. She continues to have a good performance status, 1, and her desire is to proceed with further therapy at this time. Here's a patient who was exposed to FOLFOX, FOLFIRI, bevacizumab, and cetuximab. So essentially went through 2 lines of therapy. She's microsatellite stable, so no options for immune therapy. She's BRAF wild type, so no options for BRAF targeted therapies. She's HER2 non-amplified, so no options to go on a HER2 targeted therapy, at least on a clinical trial. Her options, her standard of care options are 2, regorafenib and TAS-102. Performance status is an important factor in determining who should, 1, proceed with treatment, and 2, what treatment would be optimal. In all frankness, any patient beyond performance status of 2 should not be treated at this stage. That's a patient where we have a discussion for no therapy. The patient here is still performant and desires to have additional therapy. So the options are regorafenib and TAS-102, understanding that there's no difference between the 2 options. At least we don't know of any differences since they haven't been compared head-to-head. My preference would be to start the patient on regorafenib first, followed by TAS-102. That's the sequence I typically apply in my clinic. And the primary reason for that comes essentially from an understanding of data, an attempt to understand at least the data that is or has been presented and published in the last few years, and emerging data from ASCO GI 2018. And the understanding is that with regorafenib, we do have the RECOURSE study, which was the TAS-102 versus a placebo, had a subset of patients, about 20%, that had prior regorafenib exposure, and prior regorafenib exposure did not seem to affect the performance of TAS-102, performed as well. So we have that subset analysis. Again, it's certainly not a randomized way to think about therapy or therapeutic options, but it's a hint that regorafenib, at least placed ahead of TAS-102, does not affect outcome. The other study is the CONCUR study from Asia, where patients are typically less pre-exposed to treatments. And that suggests that regorafenib has a wider or a more steep benefit when patients are less exposed and they receive regorafenib a little bit earlier in the line. This was confirmed in a different way by the Japanese study that was presented in ASCO GI, the REVERSE trial, that suggested that if you place regorafenib ahead of cetuximab versus the reverse, so cetuximab followed by regorafenib, patients do tend to have a much better survival, which was quite statistically significant, 6-month difference. And there was also an improvement in progression-free survival. So that study suggests, again, or confirms that regorafenib, perhaps placed earlier, makes more sense. In terms of how do we dose for regorafenib, we had the regorafenib dose optimization study, REDOSE, that suggested that a strategy with going from 80 to 120 to 160 in the first cycle, so dose optimization strategy, may be the preferred way to treat patients with regorafenib than going just straight with 160. We found an improvement in the primary endpoint of the study, which was how many patients would they be able to go through 2 cycles, get a scan, and intend to go to the 3rd cycle, an improvement in overall survival, slight improvement in PFS, and then maybe also a little advantage with the quality of life.